Good morning, everyone. I am Dr. Bandhala Rajan, your ADR dermatology faculty. Today, we are here to discuss about the July 2023 FMGE dermatology recall question session. There are a good number of questions asked in dermatology. Almost 9-10 questions were asked. Almost most of them were direct. We will discuss one by one. First question. They asked trichotillomania is associated with trichophagia. This ingestion in extreme cases can lead to. The options given are trichobezoar, anagen effluvium, alopecia areata, and malnutrition. First, you know what is trichotillomania? Trichotillomania means tricho means hair, tillo means pulling, mania means it's a psychiatric disorder. It's a hair pulling psychiatric disorder. In this, most often it affects the teenage girls. When they pull the hair, they will eat also. So if they eat, what will happen? It will accumulate in the stomach and it will obstruct the stomach, something like this. This condition is known as trichobezoar. Okay. So the correct option here is trichobezoar. We know anagen effluvium, alopecia areata, those are different trichological conditions. Alopecia areata, we will see round to oval patches. Alopecia will be there. So that kind of clues will be given. Apart from that exclamation mark here, they would have given. If we condition anagen effluvium, in this anagen hairs become dystrophic and fallen off. Whenever patient receive chemotherapy or radiotherapy, the growing phase of hair, that is anagen, will fall off. That is anagen effluvium. So they would have given something like chemo or radiotherapy, diffuse hair fall. Malnutrition is not related to these conditions, so that the option is obviously out. So whenever there is trichotillomania, the patient will eat the hair will eat it, that is known as trichophagia. It will obstruct the stomach. That is known as trichobezoar. If it extends to duodenum, it's known as Rapunzel syndrome. If the obstruction extends to duodenum, that is known as Rapunzel syndrome. Next question. A child of 3 years presented with generalized vesicular eruption all over the body involving trunk. What is the diagnosis? Measles, varicella, rubella, and mumps. In this question, we need to know the viral exanthems with vesicular lesions. Viral exanthem means with other lesions. The options are measles, varicella, rubella, and mumps. This you can easily remember this MMR vaccine given na measles, mumps, rubella. This is characterized by macular rash or maculopapular rash. So MMR is characterized by MPR. So you can remember easily. So obviously the answer here is varicella, that is chickenpox. Everybody would have experienced, most of us. Multiple vesicles or blisters all over the body. So varicella is the correct option here. Now I will tell some examples of viral exanthems with vesicular lesions. One is varicella. Varicella can lead to two things. If it is a primary infection, it will lead to chickenpox. If it is a secondary or reactivation of latent virus, it will lead to herpes zoster or shingles. Right? Other conditions with vesicular lesions are herpes labialis and herpes genitalis. Apart from this herpes group of infections, hand, foot, mouth disease in children, they will have the vesicular lesions over the palms, soles, and oral mucosa. That also have vesicular lesions. Hand, foot, mouth disease. So, MMR is characterized by MPR, varicella, chickenpox, herpes zoster, herpes labialis, herpes genitalis, hand, foot, mouth disease are characterized by vesicular lesions. Now, the third question was, a patient presented with hypopigmented lesion associated with loss of sensation over the lesions. What is the diagnosis? The option here are Hansen's disease, tuberculosis, pityriasis rosea, tinea vesicular. In this, if we see the options, it's very to exclude. Like tuberculosis has various kinds of lesions. It can be plaque, it can be sinuses, but it won't be characterized by hypopigmented lesion with loss of sensation. So that is odd man out. So that is obviously out. Next, if we see pityriasis rosea. Rosea means red color. So here the lesions are given as hypopigmented lesion. So obviously pityriasis rosea is also out. In tinea vesicular, you would have seen over the trunk and the upper chest and back, you will see hypopigmented or hyperpigmented lesions. But the difference is tinea vesicular doesn't have sensory loss. It will have only skin lesions. It is a fungal infection. So that is also. Basically, it is a direct question. Whenever the patient is having hypopigmented lesion with sensory loss, you have to think of leprosy or Hansen disease. So that is the correct answer. Because leprosy is characterized by three things. If you remember this, you will answer this question easily. You can remember as S, N, S. First S is skin. Second N is nerve. Third S is split skin smear. S and S. Skin, the lesions can be hypopigmented or slightly erythematous. The nerve, it is peripheral nerve thickening, something like ulnar, radial and all. For both of these things, one important additional feature you should remember is plus sensory loss. So if they ask hypopigmented lesion is sensory loss or peripheral nerve thickening with sensory loss, the diagnosis should be leprosy. That will be the first diagnosis you should think of. Third is slit skin smear. That is slit skin smear. If we do Zadan stain, should be positive for acid fast bacilli. Okay, positive for acid fast bacilli. So in the question they have asked directly hypopigmented lesions with sensory loss. So it is a leprosy. I will just tell about other options given. One is pityriasis rosea. Here you are able to see multiple red colored papules and plaques. Rosea means red papules and plaques. Other points you need to remember in pityriasis rosea is the first lesion to appear is mother patch or herald patch. All the papules and plaques will have a scale like this. It is attaching to the plaque like a collar. So it is known as collarette of scales. Another super important point can be asked in exam is the pattern of lesions, the arrangement of lesions. If we see the arrangement, they are parallel to the axis of ribs. This is known as Christmas tree pattern or fir tree pattern. Okay. Apart from this, they can ask what is the etiological agent, that is human herpes virus 6 and 7 can trigger. Okay, these are the important points about P. rosea. If we see pityriasis versicolor or tinea versicolor, it is a fungal infection caused by Malassezia furfur. That is the organism name. In the name itself, it is given pityriasis versicolor. Versicolor means varying in color. So there can be hypo or hyperpigmented lesions. Means there can be both possibility of light colored lesions and dark colored lesions. Here you are able to see light colored lesions. Na? Same way you can see dark colored lesions. The main site is trunk. Trunk is the commonest site. Another important MCQ is if we do KOH mount, if we scrape the lesion, if we put the scales and we add drops of KOH, we will see a specific appearance known as spaghetti and meatball appearance. You would have seen a spaghetti and meatball. Why this name? It will be characterized by short stumpy hyphae. Something like a short stumpy hyphae. And multiple spores. This spaghetti and meatball appearance is also known as banana and grapes. Both are same. Okay. We'll move on to the next question. A patient presented with these lesions to the doctor and he treated with topical steroids. Name the condition. Tinea cruris, tinea corporis, tinea incognito, none of the above. First, we know what is tinea cruris and tinea corporis. Tinea cruris is ringworm. we know na, tinea is a ringworm, that round lesion with severe itching. It is most common in India. Tinea cruris means a ringworm affecting thigh folds. Tinea corporis is a ringworm affecting trunk. First of all, if you see this image, this is not a trunk or this is not a thigh. It is not clearly given. So, they won't be the answer for this case. So, these two are obviously out. We know what is this? This is incognito mode. No? Incognito mode in various browsers you would have seen. Incognito means you can't identify. Can't identify. No? So, tinea incognito is tinea which can't be identified, which is not a classical tinea. So, you should know what is classical tinea. Classical tinea is characterized by annular lesions. Annular lesions means the periphery will be prominent, there will be central clearance. Okay, this is the classical lesion. We know tinea is a fungal infection caused by dermatophytes. So, the treatment should be antifungals. But if the patient is treated with steroids, can be OTC or can be by non-medical practitioners, if they are treated with steroids, what will happen? That redness reduces, but there will be absence of central clearing. If you see the image closely, there is absence of central clearing. And there is more scaling. If a tinea patient comes to us with a previous history of use of steroids, with the lack of central clearing and more scaling, it becomes incognito. Most often we feel difficulty in identifying the condition. So the answer, correct answer here is tinea incognito. Okay. We should know the classical lesion of tinea. So it is altered, so it is known as incognito. Next question, history of burns 3 years before and patient presented with below skin condition. What is the diagnosis? Option A, marginal ulcer. Option B, basal cell carcinoma. Option C, melanoma. Whenever patient presents with burns or chronic ulcer, burns, chronic ulcer, the commonest malignant change it can turn is verrucous carcinoma, which is a type of SCC. Squamous cell transformation is more common. Burns, chronic ulcer, grafted site ulcer, those places. So, but the option is not given. Actually, marginal ulcer is other name for well-defined squamous cell carcinoma, that is verrucous carcinoma. So, it is a marginal ulcer. You will see the appearance of basal cell carcinoma and melanoma in subsequent slides, so you will easily remember. If we see basal cell carcinoma, it is common in face. In that image, it is given in legs. So, most common site is face. And another point, it is characterized by nodular lesions with ulceration. Nodulo-ulcerative lesions with the margins are rolled out or beaded. right? That is the difference between BCC and SCC. Here in the SCC, you can see exophytic growth. Exophytic means something comes out. You can remember a cauliflower. Vedic or cauliflower like growth you can remember. Okay. In BCC, it is different. For melanoma, there was a separate question asked in melanoma, so we will discuss how melanoma will look like. Okay. The next question, identify the condition given in the image. They have given some image of perianal area, I heard. I'm not sure whether the lesions are flat or verrucous. Here I put a lesion with a verrucous surface. Options given are condyloma acuminata, herpes genitalis, condyloma lata, and hemorrhoids. Previously, we have discussed in vesicular lesions, herpes labialis, herpes genitalis are characterized by vesicular lesions. But here there is no vesicles. These are papules and plaques. So, herpes genitalis is obviously out. Hemorrhoids, we know they will be having a smooth surface and they will be coming out. There will be blood discharge and all. So, hemorrhoid is also out. So, we are confused with condyloma acuminata and condyloma lata. Most often it is confusing. How to differentiate condyloma lata and condyloma acuminata? Condyloma acuminata is also known as anogenital wart. Condyloma lata is secondary syphilis. Okay. First, we will see about condyloma lata, so you can easily remember condyloma acuminata. Okay. Condyloma lata is part of secondary syphilis, na? So it is characterized by yes. Condyloma lata is characterized by, you put a yes. If one line, it will become F. They are flat, moist lesions. Okay. Syphilis, so if you put dash, it has become F, flat lesion. Flat means Latina lata. Okay. Syphilis is characterized by lata. That is flat lesions. Something like here. So it is obvious. Condyloma lata is characterized by flat lesions, but the lesions are verrucous here. Whenever we see verrucous lesions in the skin, we will mostly think of wart, which is an HPV infection. So condyloma acuminata is the correct diagnosis here. Okay. Herpes genitalis, I told, it is characterized by vesicles. The vesicles ruptures, they will be characterized by erosions. One important point is they are characterized by polycyclic erosions. It is caused by HSV2 virus. I hope you remember easily now. Lata and acuminata. Lata is yes, flat, lata. So you can remember easily. The next question is, a 50-year-old man came with lesions on extensor surfaces. On examination, painful swollen fingers are noted along with inflamed wrist joint. What is the most likely diagnosis? Option A, psoriatic arthritis. Option B, rheumatoid arthritis. Option C, rheumatic fever. Option D, lichen planus. First, we should identify the skin lesion, so it is easy for us to identify. A patient presented with lesions over the extensor surfaces. Whenever patient present with lesions over extensor, the most common diagnosis we should think is psoriasis. Lesions over the extensor, which is with if they may give silvery white scales, but here it is not given. But if they give silvery white scales, it is an additional point to confirm. So the answer here is psoriasis. Obviously, psoriasis is associated with the arthritic condition known as psoriatic arthritis, in that fingers are swollen, small joints are swollen and painful. So the diagnosis here is psoriatic arthritis. If it is rheumatoid arthritis, it will be associated with rheumatoid nodules. They are painless subcutaneous nodules. In rheumatic fever, we know rheumatic fever diagnostic criteria, na? Jones criteria, na? Jones. In the joint pain, pancreatitis, nodules. In that E, we know the E is erythema marginatum. That is known as erythema marginatum. There will be a plaque with the erythema will migrate. That is erythema marginatum. In the margin there will be redness. If we see like these three are associated with joint pain, obviously psoriatic arthritis, rheumatoid arthritis, and rheumatic fever. Lichen planus is a condition, no joint pain. It is only involving the skin, no joint pain. And another point is the lesions characteristically involve the flexure region. Flexural involvement. That is also a negative point. Okay, in this way it is easy. Extensor surface lesions towards psoriasis, so it is a condition of psoriatic arthritis. Next question, which of the following is associated with poor wound healing, diarrhea, dermatitis, infertility, alopecia? The options here are niacin, vitamin C, zinc, magnesium. It is somewhat a direct question, but you may confuse with niacin because of diarrhea and dermatitis, because in that also these two are common. But here additional points are alopecia. Alopecia is not common in niacin. So you can easily remember zinc is one of the important microelement needed for the body. So zinc is almost dad of all microelements. Needed, okay, because it is involved in various functions in the body. Why it is dad? It is characterized by diarrhea, alopecia, and dermatitis. So you can easily remember. Here you can see diarrhea, dermatitis, alopecia. And zinc is very, very important for the fertility. So infertility is also associated with zinc deficiency. So you can easily mark the diagnosis zinc deficiency. Okay. If we see niacin deficiency, it is leading to pellagra. If you want to remember niacin deficiency, in zinc I told dad, na? In niacin deficiency it is 3D. Dermatitis, diarrhea, dementia. These 3Ds can lead to 4-3, that is death. The characteristic dermatitis is it involves only photo-exposed areas. Photo-exposed areas. Okay, that is very important. Apart from that, another important point you need to remember for MCQ purposes, it is characterized by rash over the neck, The trash is known as Cassell's necklace. Okay, these are important points. If it is vitamin C deficiency, that is known as scurvy. Scurvy, we know it is characterized by bleeding gums. That is, everybody knows. It is an easy point to remember. One another important point can be asked in MCQ is, what is the hair abnormality you can see in scurvy? Scurvy is S, na? S is curved. So you can see corkscrew hairs. Scurvy is characterized by curvy corkscrew hairs. Scurvy, curvy. You can remember in that way. Next question, identify this lesion or condition. Option A, melanoma. Option B, basal cell carcinoma. Option C, hepatocellular carcinoma. Option D, squamous cell carcinoma. Here they have given a hyperpigmented or brownish macule with different colors. Here it is more dark, it is lighter, it is very light. So this image was given. So we have recently discussed now, like the squamous cell carcinoma is characterized by exophytic growth or cauliflower growth. This image, it is flat lesion, na? Flat or slightly elevated. So that will be an answer. Basal cell carcinoma, we told, is characterized by nodulo-ulcerative lesion, na? That is also out. Obviously, hepatocellular carcinoma involves the liver. There is no point in involvement of skin like these lesions. So that is out, automatically out. So the option left here is melanoma. To confirm that whether we are correct or not, for the confirmation, we will see the criteria. Like there is a thing known as A, B, C, D, E in melanoma. First one is asymmetry. Asymmetry means if there is a lesion, if we put the into 4 quadrant, if it is of same dimension, it is symmetry. But here you can see now it is extended. So it is asymmetry and borders are irregular. Second point. Here you can see it is irregular borders. Third one is color variation. First itself I told now the color is different. One area it is black, one area it is light, black, brown, lighter color. So third one is color variation. Fourth point is diameter of more than 6 millimeter. Fifth point is E. E for evolving lesions. New lesions will evolve. From this patch, some nodules will develop. Some may ulcerate and all. Okay. So by ruling out also it is melanoma. By observing these conditions, here asymmetry is fitting borders, color variation, diameter. Even this area is evolving. So it is a melanoma. Okay. Next question, which system is involved? They have given the image like this, that swollen limb, swollen one limb. The options given are arterial, venous, lymphatic, none of the above. First, we need to identify the disease. If a patient comes to you with this big leg, that is known as, we know, elephantiasis. Elephantiasis can be caused by various conditions, but most common thing we should remember in this, first thing you should remember is filariasis. Why this elephantiasis happens in filariasis? Filariasis is caused by Ucellaria bancroftina, that microfilaria, the baby filarias, will feed in lymphatic systems and it will obstruct the lymphatics. It will grow up and obstruct the lymphatics. So when we obstruct the lymphatics, it leads to reduced venous and fluid drainage from the leg, so it leads to edema. And chronic changes, the skin will become thickened, skin will become rough, dark, thick, which is known as elephantiasis, like elephant-like legs. So in this pathway itself we identified, it is due to lymphatic obstructions. So the answer here is lymphatic. Okay. If it is a venous system, you can see varicose veins. If it is an arterial system, you will see ulcers. Varicose veins, you will see the dilated tortuous veins. In arterial, it will be more of ulcers, gangrene. Gangrene is death of tissue, no? The dark lesions. So the answer here is lymphatics. Thank you guys. This recall session will be useful for you, I hope. Thank you.